Today's topic is cerclage. I have divided it into two parts. Today we are going to talk about part 1 and then we'll talk about part 2. So how to define the previous terminology about the cerclage? It was prophylactic, it can be elective, a cerclage can be emergency, it can be urgent, or it can be rescue. Of cervical sutures or cerclage can be ambiguous. More appropriate nomenclature based on the indication of cervical suture is recommended. So previously we used to call it cerclage only, but now with all the terminologies have changed with the indication of cervical suture, and that is recommended. Now increasingly used into the scientific literature. Now the definition is history indicated cerclage, and the insertion of a cerclage as a result of obstetric or gynecological history, which increases the risk of spontaneous second trimester abortion or the preterm delivery. And it is performed as a prophylactic measure, sometimes into the asymptomatic women, and normally inserted electively at 12 to 14 weeks of gestation. Then ultrasound indicated cerclage, insertion of cerclage as a therapeutic measure in cases of cervical length shortening seen on the transvaginal ultrasound. So the length of the cervix is very, very important, and ultrasound indicated cerclage nowadays have taken place for every cerclage which is being inserted. It is performed on asymptomatic women who do not have exposed the fetal membrane in the vagina, number one, and sonographic assessment of the cervix is usually performed between the 14 to 24 weeks of gestation. Then the rescue cerclage is the insertion of the cerclage as a salvage measure in case of premature cervical dilatation with exposed fetal membranes in the vagina. So there is definitely a difference between the ultrasound cerclage and the rescue cerclage, because there are chances of premature delivery. In those cases, we have to insert the cerclage in the exposed fetal membranes in the vagina. This may be discovered by ultrasound examination of the cervix or as a result of speculum or the physical examination performed for the symptoms such as vaginal discharge, bleeding, or the sensation of pressure. Now, transvaginal cerclage, which is called McDonald's, we call it, a transvaginal purse string suture placed at the cervicovaginal junction and without the mobilization of the bladder. But high transvaginal cerclage, that is also called as Shirodkar cerclage, it's a transvaginal purse string sutures placed following the bladder mobilization and insertion above the level of cardinal ligaments. Then the transabdominal cerclage, a suture is performed via laparotomy or a laparoscopy and placing the suture at the cervico-isthmic junction. Then the occlusion cerclage is occlusion of just of the internal or external os, and by placement of continuous non-absorbable sutures, and the theory behind the potential benefit of occlusion cerclage is retention of the mucus plug. Now the cervical cerclage, why we do it, what is the purpose and what is the scope of it, is since 1960s it is being used. The use of cerclage has expanded, include the management of the women considered to be high risk for the missed trimestral loss, number one. Number two, there can be a spontaneous preterm birth by virtue of factors such as multiple pregnancies, uterine anomalies, and the history of cervical trauma, for example, conization or the operation required for the forced dilation of the cervical canal are there. If there is a cervical shortening seen on the sonographic examination, we use the cerclage. However, the use and the efficacy of cerclage in this different group it's highly controversial, since there is a contraindicated in the results of individual studies and meta-analysis. Then cervical cerclage remains a commonly performed prophylactic intervention despite the absence of well-defined population from whom there is evidence of benefit, and furthermore there is a little consensus on the optimal cerclage technique. Second, the timing of the suture placement. Then it's a poorly defined, and before emergency, that's a rescue cerclage insertion, the role of amniocentesis, and the optimal management of the following insertion, and the complications are not well documented. And it's often difficult to separate the risk inherent to the underlying condition. So sometimes cerclage can lead to many complications rather than cerclage helping the premature labors. Then we have to identify and assess the evidence. The RCOG guidelines was developed according to the standard methodology for producing RCOG green top guidelines, and the Cochrane library, including the Cochrane database of systemic reviews, DARE, Embarrass, TRIP, Medline, PubMed electronic database was searched for relevant randomized control trials and systemic reviews and meta-analysis. The background is prematurity is the leading cause of perinatal death and disability. Preterm birth before 37 weeks of gestation accounted 7.6% of all live births. Although preterm birth is defined as delivery before 37 weeks of gestation, and the majority of the prematurity-related adverse outcome relate to the birth of 33 plus weeks of gestations. Mortality increases about 2% of the infants born at 32 weeks of gestation to more than 90% of those born in the 23 weeks of gestation. Two-thirds of the preterm births are the consequence of the spontaneous preterm labor, and preterm pre-labor rupture memories, PPROM, is also there. The rate of spontaneous preterm birth continues to rise globally despite the efforts of contrary and interventions aimed to reduce the preterm birth have been largely disappointing. So cerclage was first performed in 1902 in women with a history of missed trimester abortion. Spontaneous preterm birth suggestive of cervical incompetence with the aim of preventing recurrent loss, and cervical incompetence is imprecise clinical diagnosis. History which is assured that the cervix is weak, unable to remain closed during pregnancy, and recent evidence suggests rather than be a dichotomous variable cervical incompetence is likely to be continued influenced by the factors related not solely the intrinsic structure of the cervix, but also the process of driving premature effacement and dilatation. So they have got the connection between each other, and thus we have to worry about. While cerclage may provide degree of structural support to a weak cervix, the role of maintaining the cervical length and the endocervical mucus plugs as a mechanical barrier to the ascending infection may be more important. All decisions about cerclage are difficult and should be made with a senior involvement. Necessary skill and expertise to perform cerclage should carry out the procedure. Now, the history indicated cerclage. When should a history indicated cerclage should be offered? When 3 or more previous preterm births or second trimester losses should not be routinely offered to the women with 2 or fewer previous preterm births or the second trimester losses. Characteristics of the previous adverse event not helpful in the decision of placing history indicated cerclage. Sometimes there is a painless dilatation of the cervix, rupture of the membranes before the onset of contraction, and additional risk factors such as cervical surgery is one of the reasons. Now, the ultrasound indicated cerclage. When should the ultrasound indicated cerclage should be offered? When the women with a singleton pregnancy, no history of spontaneous mid-trimester loss of the preterm birth, the insertion of the ultrasound indicated cerclage not recommended in women without the history of spontaneous delivery or second trimester loss who have incidentally identified short cervix, that's 25 millimeter or less. Then evidence is 1++. There is no studies evaluating the ultrasound indicated cerclage performed solely on the presence of funneling. However, the studies demonstrated that the funneling is functional of the cervical shortening and does not appear independently at the risk of preterm birth associated with the cervical length. Who should be offered a serial sonographic surveillance, ultrasound indicated cerclage, history of spontaneous second trimester loss, preterm delivery who have not undergone the history of history indicated cerclage may be offered a serial sonographic surveillance, and evidence to suggest that those with a cervical shortening are at the increased risk of subsequent second trimester loss and maybe benefit from the ultrasound indicated cerclage, while those cervix remains long have a low risk of second trimester loss or premature delivery. Then important point is, can cerclage be recommended to any other groups considered at the increased risk of spontaneous preterm delivery? Yes. Multiple pregnancies, The insertion of history ultrasound indicated cerclage women with multi-pregnancy is basically not recommended, but nowadays we find it out all the IVF setups and people with the multiple pregnancy, they prefer to give the cerclage, which is not needed. And some evidences to suggest may be detrimental to associate with the increase in preterm delivery and a pregnancy loss. So we are worried about the preterm delivery and pregnancy loss. The chances are more with multiple pregnancy. So the insertion of the cerclage may be associated with perinatal mortality, and that's why the statistically significant. Now, do we recommend the cerclage into the any other group which is spontaneous preterm delivery? Yes, with the uterine anomalies and cervical trauma. History or ultrasound indicated cerclage cannot be recommended on either high-risk group, such women with Mullerian anomalies, previous cervical surgeries, bone biopsy, loop excision, transformation, such as laser ablation and diathermy. So these are another important. Then third is a radial trachelectomy. The decision to place a concomitant cerclage at the radial trachelectomy should be individualized. There are several cases, a series of 27 reporting successful pregnancy outcome with the use of concomitant cerclage placed into radial trachelectomy. However, the absence of control group makes it impossible to provide evidence-based guidelines on this use of the technique. And evidence level is 2 to 4 plus. Now, the transabdominal cerclage. When should the transabdominal cerclage should be considered? Previous failed transvaginal cerclage insertion may be considered. May be associated with increased maternal mortality. Can be performed preconceptually or early pregnancy. There are no studies directly comparing the insertion of preconceptual transabdominal cerclage with the insertion of early pregnancy. However, preconceptual insertion should be considered because the technical advantage of operating on the uterus of the woman who is not pregnant. And there is no evidence that any detrimental impact on fertility or the management of early miscarriage. Abdominal cerclage can safely left in place if a future pregnancy is a possibility. Now, the transabdominal cerclage, how should a delay, a miscarriage, or a fetal death can be managed women with the abdominal cerclage? Management decisions in cases of delayed miscarriage or the fetal death in a woman with abdominal cerclage can be difficult and should be made with senior involvement. Necessary skills, expertise to perform the procedure should carry out the procedure, and successful evacuation through the stitch by suction curettage or by dilatation and evacuation up to 18 weeks has been described. Alternatively, the suture may be cut, usually via the posterior colpotomy. Failing this, the hysterectomy may be required or cesarean section may be necessary. Evidence 3. So, we'll continue the rest of the cerclage in part 2. Thank you so much for the patient listening. Thank you so much.